Hi, my name is Versana Roche-Diaz, and today I will be presenting on the autoimmune disorder vitiligo. Vitiligo is an autoimmune disorder that causes patchy loss of skin coloring. In addition, hair on these regions of skin can also lose pigment and appear white. Vitiligo is a T-cell mediated inflammatory skin disorder characterized by the loss of epidermal melanocytes. The condition occurs when melanocytes, which are the skin cells that produce melanin, which is the chemical that gives skin its color, are destroyed by the body's immune system. This condition tends to progress over time. However, patches in some individuals can remain stable or even improve in some affected individuals. So genetic and environmental factors cause this condition. I will go into specifics about those factors later on in the presentation. This condition is not painful or lethal, but may make individuals more susceptible to other autoimmune diseases. Although vitiligo can develop in anyone at any age, it most commonly appears in people ages 10 to 30 years old. So it's an autoimmune disorder that has several different types. So there is generalized or non-segmental vitiligo, which is the most common form. It makes up about 90% of vitiligo cases. So in generalized or non-segmental vitiligo, loss of pigment occurs in patches of skin all over the body that often appear symmetrically. Segmental vitiligo makes up about 10% of vitiligo occurrences. Smaller patches of pigmented skin appear on one side of the body in a limited area. Universal vitiligo, depigmentation affects nearly all skin surfaces. Localized or focal vitiligo, one or a few areas of the body are affected. Acrofacial vitiligo affects skin on the face and hands and around body openings, such as the eyes and mouth. So the current US population-based prevalence estimate of overall, so diagnosed and undiagnosed combined vitiligo in adults is between 0.76, 1.9 million cases in 2022 and 1.11, so 2.8 million cases, in 2020, not 2022, in 2020. Additionally, studies suggest that approximately 40% of adult vitiligo in the US may remain undiagnosed. So vitiligo is a common disorder affecting between 0.5% and 1% of the population worldwide. However, it's actually estimated to affect up to 1.5%, including the many cases that go unreported. While the condition may be more noticeable in those with darker skin, it occurs with similar frequency in all ethnic groups. So vitiligo is caused by a dynamic relationship between genetic and environmental factors. Genetic factors include, they may increase the chance of getting vitiligo, and about 30% of vitiligo cases do run in families. So there is a lot of research that is still going on to find specific genetic markers. However, there have been up to over 30 genes that have been found to be associated with an increased risk of developing vitiligo. Two examples of these genes are NLRP1 and PTPN22. NLRP1 gene provides instructions for making certain proteins that help regulate the process of inflammation in the immune response, and PTPN22 gene provides instructions for making certain proteins involved in signaling that helps control the activity of adaptive immune system T cells. So variations in these genes are associated with an increased risk of developing vitiligo, likely because of affecting the activity of the proteins that these genes make, which makes it more difficult for the body to control inflammation and prevent the immune system from attacking its own tissues. So why do these genetic factors make the immune system attack melanocytes specifically? It's unclear the specific circumstances and mechanisms that trigger the immune system to attack melanocytes specifically. However, research suggests that the immune system of affected individuals may react abnormally to melanocytes that are stressed by environmental factors. In addition, the melanocytes of people with vitiligo may be more susceptible to stress than those of the general population, and therefore may be more likely to be attacked by the immune system. So about 15 to 25% of people with vitiligo are also affected by at least one other autoimmune disorder, particularly autoimmune thyroid disease, rheumatoid arthritis, type 1 diabetes, psoriasis, Addison's disease, celiac disease, and Crohn's disease. So environmental factors, epidermal cells, including melanocytes, are constantly exposed to stressors such as UV radiation, sunburn, stress, and various chemicals. Healthy melanocytes are capable of mitigating these factors. Melanocytes in vitiligo patients appear to be more vulnerable. This was evident in a group of factory workers who developed vitiligo following exposure to monobenzone, an organic chemical phenol, in their gloves. They developed vitiligo on their hands. So dysregulated innate activation in response to melanocyte stress triggers an autoimmune response demonstrated through recruitment of innate populations like natural killer cells, production and release of high levels of pro-inflammatory proteins and cytokines. Natural killer cells may be important players in vitiligo pathogenesis by directly responding to intracellular stress ligands, which are small molecules that transmit signals in between or within cells that are upregulated when cells undergo stress. When melanocytes are under stress due to environmental factors, signals that respond to pathogen-associated molecular patterns, or PAMPs, activate dendritic cells, which then present to CD8 plus cytotoxic T cells, causing an autoimmune attack of melanocytes. So B cells, T cells, and cytokines. So in individuals predisposed through inheritance, overexpression of B lymphocyte activating factor, BAFF or BAFF, is thought to cause a breakdown of self-tolerance, and it subsequently cause an autoimmune response by the B lymphocyte activating factor activating self-reactive B cells to produce autoantibodies against melanocytes. So breakdown of the regulation of BAFF expression results in excessive BAFF production, impairing B cell tolerance and leading to autoimmune responses. So ultimately, cytotoxic CD8 plus T cells are responsible for the destruction of the melanocytes. Stressed melanocytes secrete low levels of IL-6 and 8, which results in a low level of regulatory T cells or TREG cells that are essential for counteracting an autoimmune response. Cytokines secreted within the skin act as an early signal to help these autoreactive T cells locate stressed melanocytes. Here in the picture, we see the relationship between all of these cells mentioned. So IFN is a cytokine that promotes the activity of CD8, cytotoxic T lymphocyte, natural killer cells, dendritic cells, and cells of the other cells of the immune system. And IFN-GR is an IFN receptor on a melanocyte. So this shows the relationship between all the cells mentioned. So symptoms include patchy loss of skin color, premature whitening or graying of hair on the scalp, eyelashes, eyebrows, or beard. Again, about 15 to 25% of people with vitiligo are affected by at least one other autoimmune disorder because of the immune system already being compromised. Because they lack melanocytes, the pale parts of the skin are more sensitive to sunlight than the rest of the skin, so they will burn rather than tan. People with vitiligo may have some abnormalities in the retinas and iris of the eyes. In some cases, there's some inflammation that occurs, but vision is not usually affected. And people with vitiligo may feel embarrassed or anxious about their skin. This could cause a person with vitiligo to develop low self-esteem, which in turn could lead to anxiety or depression. So vitiligo is diagnosed by a few different testing methods. Biopsy is occasionally helpful for differentiating vitiligo from other hypopigmentary disorders. So other tests include anti-nuclear antibody tests. So an ANA test detects anti-nuclear antibodies, which are antibodies that attack your own body's tissues, targeting specifically those tissues or the cell's nucleus. Complete blood count, or CBC. Since again, roughly 15 to 25% of vitiligo patients have at least one other autoimmune disorder, the doctor may order blood tests to evaluate overall health of the patient and specific areas of concern. So again, skin biopsy is a procedure used where skin cells are removed from the body for lab examination, and this can be used to diagnose skin conditions by the removal of the abnormal tissue. Healthcare providers may also use a Woods lamp, which shines UV light onto the skin to help differentiate vitiligo from other skin conditions. Treatment includes many different methods depending on age, how much skin is involved and where, how quickly the disease is progressing, etc. So drugs that control inflammation, a corticosteroid cream can be applied to the skin. It's usually effective in early stages of vitiligo. It's easy to use, but possible side effects include skin thinning and appearance of streaks and lines on the skin. Light therapy with narrowband ultraviolet B light or UVB light has been shown to stop or slow the progression of vitiligo. It is a treatment that occurs 2 to 3 times a week. It can take 1 to 3 months before results are noticeable. Side effects include redness, itching, and burning. The combination of Sorlin and light therapy can be used. This combines the plant-derived substance Sorlin with light therapy in order to return color to the affected areas. So after Sorlin is taken by mouth or applied to the skin, the patient is exposed to ultraviolet A or UVA light. This approach is effective, but since there's a combination between the two factors, it's kind of harder to administer and use and keep up with. So usually UVB therapy, the narrowband UVB therapy is just used in replacement of this therapy. So also depigmentation can occur. So this therapy is usually an option if all the other ones aren't working. And in this therapy, a depigmenting agent is applied to the unaffected areas of the skin, which gradually lightens the skin to match the affected areas. So side effects can include redness, swelling, itching, and very dry skin. Certain surgeries can also be performed, such as skin grafting, blister grafting, cellular suspension transplant. So in skin grafting, the doctor transfers small sections of healthy pigmented skin to areas that have lost pigment. This procedure is used when there's small patches of vitiligo. Possible risks include infection and scarring, just with any surgery. Blister grafting occurs when a blister on the pigmented skin is created by suction, and then the top of the blister is transplanted onto the discolored skin. And then cellular suspension transplant, tissue is taken from pigmented skin and put into a solution, and then that is transplanted onto the affected area. Again, risks include scarring, infection, and an uneven skin tone. So about 10 to 20% of people who have vitiligo fully regain their skin color. People using these therapies, people with the best chance of regaining color are people who are young and whose vitiligo has not significantly progressed. So there's also more research going on with other treatment methods. So there's a drug to stimulate melanocytes that's underway, being researched. It's called afamelanotide, and it would be implanted under the skin to promote the growth of melanocytes. And a drug that helps control melanocytes is also underway called prostaglandin E2, and it would restore skin color in people with vitiligo, and it would be applied as a gel. And that's all I have today. Thank you so much for listening.